So a very good morning to you all, and it's great to speak in an audience which I feel that I am back to close to my second home. I lived in UK for a decade, so it's very nice memories, and a lot of things what I'm doing today is because of I lived in that country. So I'll just spend a couple of minutes what I'm doing today. I am a physician by background, and I am from Calcutta, which is eastern India, and then I did my residency in medicine in PGI Chandigarh, and then landed up in UK and worked in Bath and Royal London and University Hospital of Leicester, and became a gastroenterologist there. That's one part of the story. But while I was there, at some point I was contemplating to come back. That was back in around 2002, 2001. What I was thinking is that I wasn't feeling very motivated to come back just to India and add one more gastroenterologist in the pool. I said, what's going to make the difference? And I started looking into healthcare systems. Like, for example, if you compare the British healthcare system to Indian healthcare system, and I sort of told myself, like, we had fantastic hospitals and fantastic doctors, but as a system, we are probably 50 years behind. And further, looking at the literature, what I thought is that, what we are really lacking is organized primary care. 80% of the healthcare in UK is delivered through their GP system. And coming from Calcutta, which is the old city, we used to have a very similar system. But over the time, what has happened that our post-independence, we are very, very obsessed on two things: getting great tertiary institute like IITs and IIMs and AIMS and PGI. But there is no focus on primary care and primary education. So look, I don't know much about education, but I think I can work on primary health care. But that doesn't mean that I suddenly become a GP, and again, it will add one more GP to Indian pool, so that won't make a difference. So I said, look, I want to do systematic change. And then I realized that, well, that's a big word, and I don't know how to do it. And I thought completely ill-equipped to do so. So with talking to some people, I said, look, I really feel I need to do something. So I ended up going to a business school called INSEAD and spend a year there, work. Then from there I joined Johnson & Johnson, because I wasn't still convinced about my ability to do something, And I said, look, I probably need to learn more how so-called business world works, because I have been hardcore clinician and mostly academic. I have most of my life I worked in academic centers like Bath and Royal London, PGI Chandigarh, and so and then I thought that I will come back after a stint with J&J in UK. I came back in 2006, but I thought it would be a good idea to actually join a startup already started and try to test myself on a startup environment, because NHS and J&J is a very big organization. You don't know how it started. So I ended up starting an analytics business for them in the pharmaceutical areas, and created a 100-people organization and a several $1 million business, and I felt good about it and said, look, now what I would like to do is to move to what I want to say, that to bring back the concept of family doctor and create an organized primary care. So that's what I do. It's a chain of GP surgeries, but the difference, one of the major difference between there and here would be that we don't have a qualified primary care physician here. We have very good specialists, but there is absolutely no training program, or there is no program to become a good GP. And what I learned over there, that even for being a GP, you need a very sort of structured program for 3 to 4 years, depending on which country you are. So we'll come back to that. But coming back to today's talk, we do get a lot of invitation about talking about innovation, and I always say, look, what is that I'm doing is innovative. I don't find it too innovative, because all I'm trying to do is that somebody has done, and I'm trying to Indianize it. So there is no big. So I started looking into definitions of innovation. I don't want to bore you on various definitions, but I came up with a more practical definition. To me, is that the use of a new idea or a method, or use of a proven method in a new context. So that way we are innovative, because we have an idea. We say, look, how do you make this happen in Indian context? And I'll show you something we are doing differently. But here is the problem. whenever I go and talk to innovation, and a lot of time the talks will be on various application technology, and I really get very worried about it because many of them actually then ask, can I have your card, and they will come. And this is what I feel, that they have a solution and now they're trying to find a problem around it. To me, the innovation needs to start from, if there is a problem. Yes, there are great innovations that happen because of serendipity, as you know, that how the X-rays and penicillin was discovered, and there's nothing you can do about it. You can't plan for it, so it will keep on happening. But if you really wanted to have people thinking of organized innovation, I think we better start with a problem definition, and then find out in some kind of hypothesize alternative solutions, experiment, integrate. I mean, it's a lot of hard work. I mean, as I felt that I wanted to move from being a clinician to become more of a system manager, it was 8 years work of first going and trying to get to understand what is the business world, theoretically, then learning something on this, working in a startup. And I realized that it takes time. So I think this is a very painstaking process, and we have done that in our. So this is just what we do. I mean, as I say, that this is a GP clinic, but over the 2.5 years, we have Indianized it. So it is more of a primary care clinic focusing on certain elements, which I say that 80% of healthcare is covered, which is essentially a general practice, but women and child care, diagnostic facility, and where you have a personal doctor who you can contact 24/7. It is backed by an electronic medical record and some technology tool, which I will cover in my talk. But this is where we started, when we started looking at how do we do things differently, So rather than thinking, okay, I have got a great problem, which I am going to import GP system from NHS, we actually started talking to people that what's your problem? I mean, obviously in the context, we said, look, we wanted to, we went back to people like whom we know in Calcutta and say that, look, remember the 1970s and 80s, you all went to one family doctor, he knew you very well, and he knew your grandfather and father, how you were born. He didn't have a medical history typed to somewhere, but he had all in his head. Do you think that's very, very valuable? And we got a very solid yes. But then we asked, okay, what is that you want them to do? So we started looking at somebody like, let's take somebody like my mom. She's around 60 plus, and she has diabetes, which is a very common problem in there. So I will call her up in the weekend and say, look, Mom, how are you doing? You went to a doctor, what's your problem? And she will say, well, you know what, I was waiting for this doctor's consultation for so many weeks. And even on the day when the appointment, I was there it's a whole day affair. I mean, you go there, wait for a few hours and things like that. And as soon as I enter, and the doctor starts writing a few tests and things like that. And he's not listening to, so that's the key. So look, how do you change this? So that's a problem we found. So we found that the people do not explain things. That's far more important as a family doctor. As a cardiothoracic surgeon, probably your precision of doing a surgery is far more important. But if you're a family doctor, what the patients are looking, a little more time with you, they wanted to come, they are not trained to think like the doctors think, like, okay, I've come for diabetes, we'll talk about diabetes. My mother wants to talk about a knee pain, while you're going to go for a diabetes consultation. So there is an expectation, Of course, you will need to set the expectation right, but nobody is doing that. So, and then there is other people whom we speak. They say, look, always they will write a lot of tests, and they will say, you do this, you do that. Do I really need that? So a lot of mistrust. And there are many other issues on the profession side, but I just put for the sake of discussion that from the doctor's side, they will say, I don't have so much time. I have to see 100 patients. How am I going to take the history? So I'm not saying these are all the problem, but I just wanted to show you that what you do in setup and what we try to do. So we said, well, I felt that those are the symptoms. So what do we do? What is the underlying problem? So we started looking at, some of our colleagues, our team is essentially based off, the management team is composed of people like me, who has worked in UK for quite good time, and then the people who are dually qualified, and etc. So we looked into that. So look, in the Indian healthcare system, there are several problems which starts from the stemming from the education. We are, and even I would say in most of the Western education is very diagnosis centric. As a doctor, you have an agenda when a patient is coming. What is that agenda? To diagnose it correctly. So everything is like history, diagnosis. So you get the diagnosis and you want to do some test and that's your agenda. But the patient also has an agenda which we are not taught in medical school. And I learned when I was interfacing with the primary care physicians in the UK, they call it ICE. They say ideas, concerns, and expectation. The patient has an idea that I have this problem, diabetes, because my mother had diabetes. That's an idea. That may be wrong. But one needs to address that. They have some concerns that I will get blind. And there is an expectation that you will give a magic pill and it will get cured. Or you will I'm not diabetic, I just have some sugar. So those are the things which needs to be addressed. But we are not trained to do so. We are trained to be doctors agenda centric. So I'll come to that, just keep that in mind. The second thing what we found was purely commercial and financial. The way the doctors are essentially paid in India, which is very similar to US, is transaction or fee for service. That means every time you come to me, I charge you, I do a consultation, I charge you something. Or if I'm a surgeon, if I do a procedure, I'll charge you something. So think about it, that if you're a diabetic, I have no incentive to keep you well, but actually I want you to come back time and again. So look, if you really want to change to reduce the test and reduce the transaction, I think the model needs to move more towards patient experience or clinical outcome. That means if you have a better outcome, the doctor gets paid more. So we will come to that. The other thing is cultural issue, what we felt, is that the doctors here do not necessarily see, I use the word customer because we work in a very marketplace scenario, but they're not very culturally aligned to treat them as equal partner, if I may say so, because you have the shared decision making. Again, why this happens, if you think, most of the doctors are trained in government medical colleges, but even if you're in private medical college, the population you treat, it comes usually from the lower socioeconomic condition, and you actually develop a feeling of doing a favor. That I am doing a favor, and that doesn't change even if you are working in outside. So that mindset is there. So you do not ask, and the patients are also not comfortable to ask questions. And from as I said, that the doctor side, it's not possible to remember everything. So we said that look, you need to start with that innovation cycle. So first of all, we said that look, how do we recruit our doctors? Most of the clinics or even hospitals, unfortunately in India, that we are in a very primitive stage of recruitment. Often there will be an advertisement in local press. The doctor will call you up and they said, okay, what's my duty hours? And the employers will ask how much money you need, and the doctor is recruited. You won't believe. We are in 21st century, and that's the way you recruit. No question is what is the working environment, how will be the quality, etc. I mean, majority of healthcare providers still recruit doctors in India like that. Said, look, we will have in this environment an assessment process, which is like a 4-hour assessment. It happens like if you come to our center, every Tuesday and Thursday, the doctors come and they have to write a test for 4 hours, and I'll explain what is a test. And they're given a score, like this works like a GMAT score. With that, you can apply to some of our centers, but I will come to that. But what I wanted to come back, that what do we assess? Obviously, we assess the medical knowledge, but we also assess that who is more likely to be a better family doctor. The surgeon, or somebody like me who's a gastroenterologist, is a very masculine approach. Okay, you have come for pain, and I'm trying to get into the diagnosis of an ulcer or colitis. Whereas a GP probably might ask you holistically that what are you eating, whether if I arrange you a test, whether you'll be able to afford to do it, and so how they take the history, we try to say, okay, this is more likely to be a holistic doctor, this is more likely to be a specialist. And we have came up with a proprietary methodology to score it. So if you don't cross a baseline, We don't take you because we don't feel that you'll be a great family doctor. It is done through simulation. We will actually ask them to do some exercise and do a consultation where an actor will assess where we feel that whether you're holistic or very masculine in approach. So once that is done, we say that I think that was said. If we have to unlearn various things, as we said that in medical school we learn to be very, very diagnostic centric, or we are very, very, for example, very top-down approach. So we said, look, why it is important to be a very communicative doctor. How do you communicate well? We give them a training. So every doctors in our system get 200 hours of training. That's simple. Like we close down our clinics on Tuesday morning, bring them in one place. We have multiple centers operating in different parts of India. So we create a virtual classroom where we discuss. And again, 30% of that 200 hours is spent on consultation skills or communication skills. The third thing what we say that we will now empower with the technology tools. I mean, one example is like electronic medical records. For example, most of the clinics in India do not use electronic medical records. So we came up with an idea of a simple, I'll just show you a glimpse on that. And simple thing like that, if you are managing a diabetes, if you can connect somehow that when they are measuring their blood sugar, if they are coming automatically to electronic medical record, and we are integrating those kind of things. So once you give the technology tool, that we say, look, we need to now measure patient centricity. That means after doing all this, the patient, does he feel, my mother, said, did the doctor listen to you? Ask a simple question. Or my young daughter, who is more net savvy and who has got 20 different questions on everything, all her answers are getting answered or not. So we asked the 3 questions. Did the doctor listen to you? Did he answer all your questions? And overall, did you feel that he really is caring? We don't obviously ask that whether they know about diabetes. My mom will have no idea how to. And finally, like each and every doctor, like I have seen, let's say, 1,000 patients, and I have got a feedback of around 60%, so 600 patients, and I have a score. So I think what we did is that we completely changed the way we pay our doctor. We said that we are going to pay our doctor a fixed salary. Everybody needs that. But then you can earn much more that if your patient experience is better than others. And we said, look, not only that, we don't stop at that if we wanted to encourage doctor to continuously update, you're going to assess them on knowledge and competency. That gets into their performance score. Then what we are working on, that whether we can tie clinical outcome. If I have got 100 diabetics, and you have 100 diabetics, if my HbA1c of my population is 6.5 and yours is 7, probably I'm doing a good job. I know it's very simplistic. I'm sure there will be a lot of eyebrows coming up. But I'm just saying that that's the way to move. That we need to move away from fee-for-service to more outcome and patient experiences. So that's the innovation. But how do I pay your doctor? So I'll show you what is the problem and how do you move. And you use technology in that. But it is not that you have a solution and you try to fit the problem around it. As I don't want to spend too much time. This is an electronic medical record we developed, but we felt that as a GP, what you need is a very, very simple. There are a lot of complex things, but what you need in today, a GP will be going in an outpatient, or they're going to sometimes we have corporate clinics or home visits. So something like a tablet where they can put quickly a few things, and a summary. One of the problem is the electronic medical record is get very episode based. Like I used to be, as I say, gastroenterology registrar, and I used to chronic patient like Crohn's disease. Patient will come and I know that I have to see 40 patients, and you see a thick file. You don't know what's going through my spine. And I'm desperately looking at the back of the notes if some registrar had summarized it well. So what you need is a summary which actually be able to cull all the important information in a 1-minute snapshot. So we came on that, and they said, look, if I have to pay my doctors on hypertension targets or HbA1c target, we need data analytics capability, and we are working on the future mobile application on smart card. So what I wanted to tell that the innovation does not mean discovery of the new things. It could also include the use of tried and tested process, but in a new context. So always my favorite is that do not try to plan 100%. plan 70% and then learn the things while you're doing, see what is required. Sometimes it's a change of way of doing it, sometimes it's this technology, but it should be centered around the problem you're trying to solve. And we shouldn't be doing innovation for innovation's sake, but it should try to improve on something. So that's my summary, but say I'll be happy to take any question. I don't know how I kept to the time, but
Great,
yeah,
thank you. I think we're going to open the floor for questions. I have some of my own, but I think do you want to identify yourself as well? Yeah. Do we have a roving mic?
Yeah, I'll be speaking for the other thing. No? So what is the business model on this? Obviously, you're not running this for free.
Of course, I mean, business model is simple. We had in the beginning, we had a very subscription-based model because coming from UK, we thought that it will be great to have a subscription and not to worry about that. But we found the takeoff is pretty slow if you push 100% subscription. So we have a combined model where a patient can come and just pay us a fee for a single service, and then take the service and you charge them. And then we have a subscription model where a patient comes and pays a lump sum fee where it will be more like a GP given to you. Or we also have a corporate model where we go and approach a company where a GP will be deputed 2 hours a day in your company at lunchtime or something like that. And then rest of the time he is connected through the virtual world. I mean, you can talk to the GP virtually through phone or an email, or you can come in. So it's very simple.
So how many? Is operating a franchisee, or you're running everything directly?
See, one of the key point, what I didn't touch. If you say that, look, there are a lot of clinics. What is the difference? The difference is in doctors' training. We do not work with consultant doctors who will come and operate from here and there. We take full-time doctors. We assess them thoroughly, find out who will be better likely to be a family doctor, and then give them 200-hour training, and we have a 3-monthly assessment. Like India does not have a requirement fit to practice. So we created a fit to practice inside, and it's very strict, like it's every 3 months rather than once in a year. So that's, it's like that.
So how many centers do you have in the country?
We have 2 kinds of center. One is open for public. We have 9 centers, 7 in Bangalore and 2 in Gurgaon. It's all came up in the last 2 years. And then we have 14 corporates, which are like satellites. These are like small, mini clinics within the companies. Yeah.
Thank you. Very nice.
Thank you kindly. Excellent presentation. On the question of EHR, great idea. Who knows, one of these days they might catch on. What are the standards that you're going for? Are they sort of ICD, SNOMED CT? And sort of supplementary question, what's your policy and practice on sort of patient access to the EHR?
Yeah, I think one of the great things, plus and minus, India is not at all regulated, so you can do a lot of things which you think is right. Yes, we follow ICD-10. So we are working on, initially we started our own EHR, and then we realized that as a provider this is not our core business, so gradually we are looking for now partner to outsource, but we have our ways of doing that. Access, we give full access of patients to our EHR from day one. We feel that that's, it's improving and learning on what we have seen in the UK system. At least as long as I was there, wasn't there, but I felt that is very, very important. But there will be one section which is not, like for example, I put something like query cancer. It is for my own notes. So we call it doctor notes, which is not visible to where you put your doubts and things like that to let your colleagues know. But other than that, all the other parts of the section is, it's secured. It is through a password. You can access it and you can take a printout and things like that. Good question. Again, because the regulatory framework says we own the data along with the patient. Yeah.
So you're looking at primary care, and you're developing an ICT framework around that. Within the UK, as you know, primary and secondary don't have integration. So when you do send a patient that goes into a hospital, how do you manage the data from that environment to come back into you within this service?
Absolutely nothing. It's completely fragmented even much more fragmented than
How
there.
would that impact your business as a?
Well, as I said, that look, that's, I mean, that needs to come into a much bigger platform. Somebody needs to come with a platform, and then go there,
Oh, funny
We will
you
not
say
be-
that.
Yeah. So we know there is a consortium approach where people are trying, but that's something I don't think we just as in one organization can solve the problem. Yeah.
It's a massive problem.
It's a
as
massive
you know,
problem. It's a massive problem. Even simple thing like we do not run our own labs, so we actually take the blood and then pass it on to the labs. We are not integrated, so forget about any other player. Now he has a system, I have a system. Now why is he going to change with me, or I'm going to change with him? There's a massive challenges. So I
Yeah.
don't think we can just, yeah.
My name is Sanjay Bhardwaj. I represent a company called Fatback Technologies. Very impressive presentation, Dr. Shantanu. Well, I've been following your business model for quite some time in India. We work in public healthcare space, where we basically design and implement very elementary and basic solution for primary healthcare centers in India. And networking at the back end with the district hospital. You know the healthcare infrastructure in public space in India. Other than the technology and providing the infrastructure, the basic challenge that we face is the training of the doctors and paramedics, more so in the government sector of public healthcare space. Well, we have actually interviewed a whole lot of doctors, and they have never actually sat down in a classroom for about 7, 8 to about 15 years. So the challenge that we find is how do we build up the capacities there, whether with the doctors or with the paramedics. So will your company be open for some kind of a collaboration or knowledge sharing with the so-called people from public healthcare space and see, how we can build up capacities?
Absolutely. I mean, while, as I said, that while you see the front face is a chain of GP clinics, and I don't think there is anything new about it. What is unique about is the commitment to training. What we are trying to do, creating a cadre called primary healthcare specialist. I just want to spend here 2 minutes because it's very, very, recently I see a lot of things going in newspaper talking about you need to produce more specialists. But what my thought is that rather than creating more and more vertical specialists, we need to create horizontal specialists. What I mean by that, if India goes to the route of the specialization, that for one person you need in a primary health center, you will then need a gynecologist, you will need a physician, you need a surgeon. And how our training happens. As a surgeon, I'm also learning to do an appendix and also a very complicated colorectal surgery. What we need, like in a rural area, what you need somebody who can actually do a cesarean section, also an appendix, and can treat a pneumonia. And if you're in office-based practice, you know how to treat diabetes. You also need how to take infected toenail, or how do you put an IUCD. So we have to completely change the way we think about we just cannot blindly follow some Western model. So I believe that we need to create a cadre of what you call horizontal specialists, and that's what I'm trying to do, is to creating a cadre of office-based horizontal specialists, what you call family doctor. And I think that's the way to do the change, and that's what I'm proud about, and that's what I feel is unique about my organization. And that's the part of the organization I want to spread, because creating multiple clinic has a scalability, but this is the way we can scale much faster. And in fact, we are actually working on the back end to see how do I take this program to even people who are not working for Nationwide. And somebody spoke about a franchisee. I mean, we wanted to establish that first. There has to be something what the franchisee get from me. I mean, after I put that thing, put a banner for 1 year, he has made it break even, then there is no need for me to be there. So what is that, what I can produce in the long run, which is beneficial for the doctors, what we're looking. So I'll be very, very keen to work, particularly the public sector, because public sector needs it more than private sector.
Yeah, because I would say that, the knowledge base of some of those people is abysmally poor today.
Yeah.
And this is where we find a lot of challenges in, scaling them up.
Yeah.
So we are a technology company, we can't do that. So we need probably someone like you who can, bring in
We will
those
be definitely,
slots.
and as I said, we on the other hand, try to get into developing technology ourselves. We are a user of technology because that's not our core competence. And we have tried doing that, and we said it's not a very good thing to do because we just want to focus on what we are good at.
Great, thanks a lot. Thank you.
startup. So I guess I was wondering, like, I'm guessing right now mostly you're based in urban centers, right? So do you have plans to try and grow it out into some of the like rural areas and like have like the regular training sessions there? Because it seems like that's what a lot of the
Yes.
like healthcare workers there really
I think
need.
I am a strongly believer in sustainable model. We haven't yet found a clearly sustainable model for rural area. There are a lot of other challenges we won't be able to solve immediately. So we felt that let us start in the urban area where we will be more likely to make it sustainable, and then probably work with the public sector. Like for example, if you look at the UK GP model, it is one of the greatest examples of a public-private partnership, like where you are contracting your work out to a private entrepreneur. That's what the GP model is about. And we are hopeful that we are able to, once we show the results, like the outcome-based results. Currently, if you go to all the partnerships are based on transaction. So look, I will take up your population, and I'll actually show you that I can actually give you better outcome or better compliance, like your vaccination rate or sterilization rate, and as I say, blood pressure targets. And we wanted to approach public, but it will take a little more time.
I guess I was just wondering, how is your telemedicine run right now? Is it like over internet connectivity or satellite, or?
See, when we say telemedicine, it is mostly on phone. We do not use. We do not have a clinic where there is not a doctor on the. At the side where you're using a facility. We have looked into it because telemedicine. If I am to do it, let's take the rural. It solves only one problem. There are three things you do in a medical practice apart from, in a day-to-day practice. You actually consult and examine and you diagnose. Then you run some test and then you need to give some medicine. Now I have been looking at this telemedicine model very closely and traveling in rural areas. So all you are solving is the first problem. You still need to arrange a blood test. You still need to, so that physical infrastructure you are not able to take away. So telemedicine doesn't solve all the problem. It has to find out a solution for everything.
Also, just wondering for your weekly training programs, is it possible to set the infrastructure for that up in more isolated areas?
Yes, I think that's what I was trying. Like today, what we are working on. When we started in Bangalore, it's only in Bangalore, so we said all the doctors come in one place. Now we are 3 places because we have National Capital Region where we are doctors here, and our trainer who comes once in a month in Bangalore is based in Calcutta. So we are looking at the virtual environment, and we are very keen on that. That how do we use more virtual environment, have a better learning, then we will be able to reach much better. One part is creating clinics, but the other part is taking this education program to a larger number of doctors and making them and have them a backup. It's not the education like if I'm practicing in rural India, so if you have a backup, you call up. So look, what do? I have this problem. So this is the way we will, we will be able to, like we say, our mission statements say, a qualified family doctor for every Indian family. There's no way us organization can do that for 1.2 billion. So what we want to do it is this way, that we want to reach and create touch points, and we are very keen on those kind of things.
Thank you.
Any other questions? Yeah. So can you get a mic?
Yeah.
How easy it is for you to get some good clinicians into this?
In fact, it is much easier because, as you said, the craze. We did a survey. We surveyed 100 medical students in India. Said how many of you want to be GP, and there's no surprise here. In the UK, if you run this, it varies from 20 to 40%. In India, it was less than 1. So, but that's the aspiration. Now, as you know, there are 40,000 doctors pass out from medical schools. Only 10,000 get to a PG, and there are 30,000 doctors who doesn't get a specialization. And it's that one particular doctor may try again, but there is a cumulative pool of, let's say, for last 10 years of 300,000 doctors. Now think about it. What is the career structure in India? It's horrible. We don't use these doctors at all productively. What they do, they can join a government service, but many of them don't want to for various reasons. But the rest of them will be working in either a sort of a very unorganized structure, in small clinics, or in bigger corporate hospital as a resident doctor rest of their life. So they're very, very frustrated. And that's a large pool. and we actually approach them. We are not going to approach a cardiothoracic surgeon, and we try to take the best of them. So if you like for like, two data I want to give you. For every doctor we recruit, we reject 4. It's not that we want to reject, but to show you that we are actually able to choose. To get good type, you want to get the top 20%. And secondly, an MBBS doctor attrition rate in hospitals goes sometimes up to 60, 70, 80%. Our attrition rate is 12%. The reason we are able to do it, that we are giving them a career. It works like a management consultancy firm, where over 8 to 10 years you become a partner. You get, institution is spending money on you, 200 hours of training with a lot of focus on that. And number 3 is you work in a peer group with a better work-life balance. And outside, these doctors, as I said, they will be working in a hospital, doing night duties, no recognition, so we are able to attract much more.
Hi, my name is Raj and I work with Biospectrum magazine as a journalist. My question is, you said the doctors get trained for 200 hours. So what does this trainings comprise of?
Okay. We actually take a curriculum. As I say, we are in the family doctor, so we actually took a curriculum. For example, as I said, that's why I'm very, very thankful to my training in UK. We took the Royal College of UK curriculum, we Indianize it, and then we created modules. Like it will be hardcore science, like a diabetes or something, but rather than focusing on basic science on the treatment and things like that. But one of the part which we are very, very proud, is around 25 to 30% of our training is focused on consultation or communication skills of doctors. What we do is that we give them some basic, but then more important, like the doctors have to do a consultation with an actor patients. And you video that out and play it back to them and show them. And then there are trainers who will go and sit with you during the actual consultation and give you feedback. So essentially 2 components. We call it science and art of medicine. In medical education in India, nobody focuses on the art. We have never been, even I was in PGI, which is so-called epitome of medicine in India. But we have never been told that if somebody has died, how to go and tell him, we just go and tell him you have died, So that's, so I think that's what we do. Yeah. It's
Thank
simple.
you.
I see, as I said, I do not believe in high profile, thinking. It's very, very simple that this is what you need. What does an Indian family doctor practicing in Bangalore needs to know? So we come up from there, break it into module. I can't teach you everything. Some will be you have to self-study. Some will be taught. Some will be helped with simulation. Somebody, so it's simple things. Yeah.
Thank you.
I have a question for you. Thank you. That was very, very helpful. Thank you. My question is, what would you say are your 3 biggest challenges?
Good questions. I may have to think a little bit because we always thought that in the beginning, as the gentleman was pointing out, how do I going to motivate my doctors to become a generalist? That's a challenge. But I think we have done a good work. We do get a good flow of this thing, The other thing is, the biggest challenge is how do we scale up faster? Because it's a very brick and mortar kind of thing. You go and find out a place, say, look, this is the property, then there will be a team who will go and assess that. There's a legal due diligence. Take 3-4 months to find out a center, lock it, getting it that. So we have to find maybe a technology or something where you can at least touch people's life faster. I mean, I may not be able to give that. So that's one thing what we are always looking. Number 2 is, I think, because we work in a marketplace kind of situation as opposed to UK where government is coming in a regulatory way. So how do you make sure that convince the market that this is the way to go? Like in 1970s, everybody will say family doctor, but today one might argue, although it's a small minority, that look, I have a hospital, I'll just go there. They don't necessarily always see because they haven't seen. The newer generation may not have seen the value of it. The third is purely financial. I think the Indian healthcare models are based on a very pure model where as an inpatient, if you look at the profit and loss, you try to get the patient you give things at throwaway prices for outpatient. The idea is they are the places where you take them, bring them in the hospital, and you charge them well for the procedures. And this is the opposite. We are taking a contra view. Said, look, I don't want to refer you to the hospital. I will resolve more. So, but then yet you have to compete with the hospital with the price. And then there is a rental, you have to pay the salaries. So it's, because it's a model needs to be established, as I said that most of the healthcare model is based on the fact that finally the patient will come in inpatient where you'll be able to charge them in a much bigger way. So that's
Very interesting. I mean, I think the three things you said, they're all linked.
yeah.
The whole scalability challenge.
Yes. Yes.
And
Yeah.
the economic backdrop.
Yeah.
You're trying to bring about a paradigm shift.
Absolutely, that's well, yeah, and that's not easy, and that's why we start with, as I say, I always say, if somebody wants to start with a single unit model. I mean, you try to prove your sustainability at that level. So it's easy to say and get emotional about I'll go and do in a rural area. I'll do it for a year or two, and then we'll back off. The reason the fact that we haven't done it led to the fact that we are surviving and bidding. We got our venture capital funding, because we said, look, let's focus on where it will be easy, prove that our clinics are breaking even, making reasonable amount of profit. It's not a big this thing, where people say, okay, this is looking interesting. If you could do that so early, how do you make it more sustainable? Yeah.